Today we'll talk about an approach to a non-variceal upper GI bleed, or what is traditionally called an ulcer bleed. So whenever a patient presents with hematemesis or melena, broadly we classify that kind of bleed into a variceal bleed or a non-variceal bleed. But in majority of situations, at the time of index presentation, we won't know whether it is a variceal bleed or a non-variceal bleed. Today we are going to be talking specifically about the approach to and the management of a non-variceal upper GI bleed, specifically an ulcer bleed. So a non-variceal upper GI bleed does not necessarily mean that it's always an ulcer. It could be other things. It could be a GAVE, it could be a dialophoid lesion, it could be even a tumor bleed. But today we are going to be talking about one of the most common causes of an upper GI bleed in an individual, that is an ulcer bleed. So this is the case scenario. This is an elderly gentleman. He has a history of stable coronary artery disease. He's on a single antiplatelet, a low dose of 75 milligram. He presents to you with upper abdominal pain as well as 2 episodes of hematemesis and melena with syncopal symptoms. On evaluation, his vitals are, his GCS is okay, his pulse rate is 122, BP is 165, temperature is normal, there is mild epigastric tenderness. So this is the clinical situation. A lot of information can be gleaned from this. First of all, even if in cases of variceal bleed also, you can have upper abdominal discomfort and pain as a result of pooling of blood or the vomiting sensation itself. Traditionally, pain associated with hematemesis will go more in favor of either NSAID-induced bleed or an ulcer bleed. Secondly, presence of syncopal episodes will give you an understanding that this is a very significant bleed that you're dealing with. So this is not something that you will ignore or manage conservatively. This patient will definitely require an endoscopy, however, only after stabilizing that patient. And luckily his BP is normal. You don't require inotropic requirements, but in view of his syncopal symptoms, if this patient reaches the emergency, you should be perceptive enough to look for a backup ICU so that this patient can be managed well, his bloods can be collected, transfusions can be given, and endoscopy can be planned. So his hemoglobin is 8.7, his platelet is 2.3 lakhs, creatinine is 1.2, bilirubin is 1.2, AST/ALT is 56/72, albumin is 4.1, and PTINR is 1.2. So now I'll give you a couple of clues which will help you glean out which are the ulcer bleeds and which are the non-ulcer bleeds. It's very difficult to find out for the first time when a patient presents to you with an upper GI bleed whether it is due to a variceal bleed or an ulcer bleed. Of course, in patients who are under your follow-up, who are established known cases of chronic liver disease, whenever they come with upper GI bleed, you automatically assume that you could be dealing with a variceal bleed. For a person who comes to you for the first time, on history, pain abdomen, presence of antiplatelet usage or presence of usage of NSAIDs, history of CVA or CAD in the past, all these factors will go in favor of an ulcer bleed over a variceal bleed. But you should know that even in patients who have chronic liver disease, very commonly whenever they present with upper GI bleed, it could be an ulcer bleed and not a variceal bleed. So on biochemistry, what are the tips and tricks that you use to find out whether it is an ulcer bleed or not? And why is that important? It's important even prior to the endoscopy to find out or at least predict whether it is variceal or non-variceal, because the management of a variceal bleed, the medical management of a variceal bleed is completely different from the medical management of an ulcer bleed. In a variceal bleed, the pathology behind the bleed is portal hypertension. So you will be giving medicines to reduce the portal pressure at the time of presentation if you are predicting or you know with surety that it is a variceal bleed. For example, we have medicines like terlipressin, somatostatin, and octreotide. All these medicines which will work primarily in causing vasoconstriction at the splanchnic circulation so that you have reduced blood flow through the portal pressures into the varices or the fundal varices. However, in ulcer bleed, your medical management is pretty straightforward. We are all aware of that. You have to give high dose proton pump inhibitors as an infusion or as a bolus dosage. So with this background, you need to understand how to predict. And not only you as a gastro resident or a medicine resident, this I would say is an very essential requirement for anybody who practices in the field of medicine, who is in the zone, who is going to receive the patient, especially at the level of ER, casualty, clinical medicine, etc., etc. So point number 1 is the patient's platelet count is 2.3. That's a normal count. That is a very strong pointer that will help you assess whether it is ulcer bleed or not. Thrombocytopenia is the first biochemical parameter or the phenotypic expression of portal hypertension. So whenever a patient has got a normal platelet count, I'm not saying that I would completely rule out portal hypertension, but I would definitely think more in terms of an ulcer bleed. However, this patient's platelet count was probably say 75,000 or 1,20,000. The significance is not that the thrombocytopenia has caused the bleed. The significance is that because this patient has got thrombocytopenia, I would definitely rule out chronic liver disease as an etiology behind an upper GI bleed. Point number 1. Point number 2, you look at the AST and the ALT ratio. So one of the cardinal features of chronic liver disease in general and alcoholic hepatitis in particular is a high ratio between AST and ALT. So for a lot of reasons which I will not go into, chronic liver disease patients will have a higher AST-ALT ratio. When you have a thrombocytopenia associated with a high AST over ALT, you would and should think of variceal bleed as a manifestation in these patients. Point number 3, albumin level also will give you a certain clue. Again, albumin levels being low or high does not have much to do with portal hypertension. However, because chronic liver disease is the most common cause for portal hypertension in humans, a persistently low albumin level, say less than 3.5, would give you a clue that again this is probably chronic liver disease that you're dealing with. Finally, PTINR, despite all the hue and cry around it, is not a very dependable parameter. So if you have a deranged PTINR, it could be due to reasons other than a chronic liver disease, because in chronic liver disease you have a coagulopathy where you have imbalance between antithrombotic and prothrombotic phenomenon that shows in multiple different ways, and PTINR is just one manifestation of that. So I would say that rather than depending only on a PTINR, obviously if it is grossly deranged, you would think of other causes. But other than PTINR, I think you should focus on the platelet count, the AST-ALT ratio, and the albumin level. Now, if you suspect this, what are you going to do in front? Because in a lot of situations, you may not be working in high volume centers where you have the luxury of doing an emergency ultrasound prior to the endoscopy or a CT scan prior to the endoscopy. But having this information, maybe in the selected group of patients, you can ask for an ultrasound abdomen as fast as possible. And even if there is a delay in endoscopy, when you are resuscitating the patient, maybe you can start these patients on medicines for the particular pathology, whether it is variceal or non-variceal bleed. Now, with this background, so this patient does not have thrombocytopenia, this patient does not have an altered AST-ALT ratio, this patient does not have an abnormal INR value or an albumin level. So the first approach is, what are the relevant anatomical considerations that one should be aware of in peptic ulcer bleed? Now we're going to assume that this case scenario, this is most likely an ulcer bleed. So using this case scenario, I'm going to go through certain aspects of an ulcer bleed. So the anatomical considerations are, first thing you should know is what is an upper GI extension. An upper GI bleed is a bleed that arises from anywhere between an oropharynx and the ligament of Treat. So ligament of Treat is a pull-up of the ligament that somewhat differentiates the proximal jejunum and the duodenum from the rest of the small intestine. That's your first understanding. Secondly, in the stomach, you should know that the lesser curvature, especially towards the antropyloric area, is an area that is very commonly associated with an ulcer bleed. Thirdly, in the duodenum, it is usually the first part of the duodenum. Now, why is that important? So when you do an endoscopy, and if you have seen performing endoscopies, people performing endoscopies in your hospital, you'll understand that when you do a quick colonoscopy, especially when there is quick endoscopy, especially when there is a lot of blood in the stomach, it's very easy to go across the D1 and then you do a particular maneuver and turn towards the second part of the duodenum and the third part of the duodenum and come back. It's very common for beginner endoscopists to miss out on a complete examination of the first part of the duodenum, which is called the duodenal bulb. Now, why is that? Because the duodenal bulb is one of the shortest aspects of the different parts of duodenum. Secondly, in the posterior aspect of the duodenum can be easily missed unless you go in and then come back and spend a good amount of time looking at all the walls of the duodenal bulb. So the anatomical importance of this is, you are going to look at the lesser curvature, you're going to look at the first part of the duodenum, with extra care in a patient who's presented to you with hematemesis. So this is this area, and this is the lesser curvature, especially towards the antropyloric region. I'm not going to go into the complete blood supply of the stomach, but you should know that the lesser curvature of the stomach that we talked about is supplied by the left gastric artery, which is a branch of the celiac artery, and the right gastric artery, which is a branch of the common hepatic artery. So you have the left gastric artery and the right gastric artery supplying the lesser curvature. Now, sometimes what happens is you see an enormously large ulcer with scarring and abnormal tissue around it somewhere along the lesser curvature, and sometimes it could be due to an erosion of a left gastric artery. So there are very certain situations in which you would be much prepared to deal with a massive upper GI bleed. So in these situations, for example, if there is a large erosion or scarring, or I see a large visible bleeding vessel more than 5 millimeter, I will not be usually going with the run-of-the-mill endoscopic accessories. I'll be going with the big guns, expecting that this is going to be a torrential situation. And secondly, if it is not a high volume center, I might even send these cases for a direct transarterial embolization from an IR, and very, very, very rarely to the surgeon, or at least have a surgical backup before you do these procedures. Now, in the greater curvature, you have the left and the right gastroepiploic arteries. So the left gastroepiploic artery is a branch of the splenic artery. So from the aorta, you notice that the splenic artery is moving like this. One of the branches of the splenic artery is the left gastroepiploic artery, which supplies the greater curvature. And also you have the right gastroepiploic artery, which is a branch of the gastroduodenal artery. So if the lesser curvature, you have the left and the right gastric arteries, the right curvature or the greater curvature, you have the left and the right gastroepiploic arteries. Whereas in the fundus, you have branches of the splenic artery. You have the short gastric arteries and the posterior gastric branches, which are arising from the splenic artery. In the blood supply of the duodenum, the most important concept is the gastroduodenal artery. So the gastroduodenal artery, which usually supplies the duodenal bulb, can be seen in very close approximation to large posterior duodenal ulcers. So again, if you have a deep ulcer in the posterior duodenum, if you see a visible vessel, you should probably be aware that this is one of the branches of the gastroduodenal artery, or sometimes the gastroduodenal artery even. So if you have direct spurting from that, you need to be very sure that you are capable of doing this, or send this case to a transarterial embolization or a surgical management. Now, why is this important? For other reasons is, when you do endoscopic ultrasound, very commonly you take your endoscopic ultrasound to the first part of the duodenum and try to get EUS FNA or FNB samples from the pancreatic head region. One of the things that endosonologists take care of is that we always look for the gastroduodenal artery and try to avoid it when you're taking a puncture of an EUS FNB or an FNA. So that is one good way for you to think about gastroduodenal artery being in close approximation to the first part. Now, overall, the duodenum is supplied by the celiac artery and the superior mesenteric artery, multiple branches of the celiac artery as well as the superior mesenteric artery. The proximal, you can divide it into proximal duodenum and the distal duodenum. The proximal duodenum is supplied by the superior pancreaticoduodenal artery. This is a branch of the gastroduodenal artery. So you have the gastroduodenal artery coming posterior to the first part of the duodenum and dividing into the superior pancreaticoduodenal artery. This is what supplies the first part of the duodenum. The distal part of the duodenum is supplied by the inferior pancreaticoduodenal artery, which arises from the SMA. So the celiac gives the superior pancreaticoduodenal artery and the SMA gives the inferior pancreaticoduodenal artery. You have an arcade, and that's where the duodenum is supplied. But the proximal duodenum is where most of the situations you're going to face an ulcer. With this anatomical background, what is the role of diagnostic radiology in non-variceal upper GI bleed? So we don't routinely do an upper GI CT angiography before every case of an upper GI bleed. However, in situations where there is severe hemodynamic instability or the patient is severely exsanguinating in front of you, you might do a CT angiography. So the role of diagnostic radiology, you can divide it by two. One is CT angiography. In CT angiography, you'll be able to see active extravasation with around 85% accuracy. But the problem is, if the patient has bled and the bleeding has stopped, in these situations, it has got very poor sensitivity in predicting where is the location of the bleed. In addition to that, you have something called a catheter angiography, which is called a direct angiography, in which you have an added advantage of performing therapy also along with the same setting. So in cases where your endoscopy has failed, or where the patient is severely exsanguinating in front of you and you don't have time to do an endoscopy, or the patient is not fit for an endoscopy, in these situations, your interventional radiologist can perform a catheter angiography, put contrast, find out where the contrast leaked, and give therapy in the form of coils or embolization in the same setting. Whereas tagged RBC scans are not very useful in the scenario of an acute bleed where there is hemodynamic compromise. So before you do an endoscopy, how are you going to stratify the risk of the patient? So this is called the pre-endoscopy stratification. So endoscopically is where you can clearly find out whether it is a high risk of rebleeding or a high risk of bleeding, a high risk of rebleeding or a low risk of rebleeding. But before you do an endoscopy, what are the scoring systems I can use? One is the Blatchford score. So the Glasgow-Blatchford score can be used primarily to rule out cases which will require admission in the ICU or in the ward. For instance, a Glasgow-Blatchford score that is less than 1 or equal to 1 reflects a very low risk or requirement of transfusion or a very low risk of re-intervention. So these patients, obviously they will require an endoscopy, but if you can do an elective endoscopy, probably say the next day, these patients can be safely discharged. However, these are all Western guidelines. In our neck of the woods, we don't usually do this for multiple reasons, because access is easy here. Whenever we have patients who have an upper GI bleed, it's better that you admit them and do an endoscopy. But maybe for this group of patients where the Glasgow-Blatchford score is 1, you can even wait for the next day.